Welcome back to the Birth Blueprint. I'm Michelle Gabriel Caldwell, Director of Doulas and Education. And with me is Chadira, our resident midwife, and Rosemary, our Director of the Birth Center. You see somebody missing? It's Dr. P. She's at a birth and will be here soon. Rosemary will be facilitating our conversation today on the midwifery model of care.
Yay! Birth happens, guys, so I'm going to do my best to, cover Doc. But you also had your birth.
I did.
Just a few minutes ago, right? Like half an hour or so ago. But... And then you just slide into the pod after that. Yeah. Birth happens any time of day. It doesn't matter at this point, right?
Yeah. Well, I was at a birth too a few hours ago.
Right?
Yeah.
This
morning.
Wow. Look how refreshed
we almost didn't make it.
It's a look. It's a look.
So, in this episode, I wanted to talk about the midwifery model of care. I really wanted to discuss in depth midwives and what they bring to the OBGYN world. So, can you tell me what is a midwife? And I know we've explained it before, but I really want people to understand what a midwife is versus an OBGYN.
Okay. So, the name itself really means with women. So, in a nutshell, that's what we are. We're providers that are with women throughout their labor process. Of course, prenatally and postpartum, but within the labor space, we're there to kind of support and provide, guidance throughout the labor process by trying to avoid interfering with natural labor, if that makes sense. So we're the same as OBs. We are trained medically to take care of you, to help deliver your baby. We just work more so with low risk. I feel like with doctors, they're more so working with high risk women, so they tend to intercept in deliveries more so. We kind of help the process just glide as it goes while still monitoring and making sure that mom and baby are okay, but also allowing your body to do what it was made to do.
But midwives come from eons ago, right?
Yeah.
So
even before OBs, technically.
Way before OBs.
Yes.
So why is this? It's maybe it's just me, but I feel like it's the comeback of the midwives. It's like we're coming back and we're coming back stronger than ever.
Chadira can speak to this as well, but the history of midwives in just the US alone has been a real kind of downplay of the work, right, that was done, because to your point, doctors sort of showed up on the scene and was like, no, we don't need you. Yeah. We got this.
Yeah.
And you're doing it wrong. There was also that kind of vibe.
Yeah.
And so really bringing it back to what was normal, natural, and physiologic, because our granny midwives were doing it. And
because it wasn't cost effective, right? So
now there was a way to get money for it.
Yeah.
Because before it was bartered and it was foodstuffs and just, all those types of ways to just support families. And there was a village, and it was just a very wonderful kind of experience, and needed in that ways. Now it's a little bit different because, midwives kind of came back and they didn't look like we look.
Mm-hmm.
Yeah.
Right?
Yes.
And they were in the 70s and the 60s, and they were doing this whole, return back to the earth vibe and that kind of thing. And you have people like Anna Mae Gaskin who kind of really learned from granny midwives and kind of took that and ran with it. And so she was kind of looked at as the pioneer for midwives and the midwifery model of care. And that's really not what it was. We have to really credit major women who were doing this work way before.
Exactly. So it's the roots, right? Mm-hmm. So you go back to the roots and the foundation, which are the midwives. And I feel like a lot of patients aren't well educated on that. And they'll come in and be like, I want to see a doctor. And don't get me wrong, Doc is the legend, okay? And we're going to pat her back for her. Because she is the myth, she is the legend, she is the woman. But they come in here and they're like, I want to see Dr. Pemberton. But want this low risk, not saying doctors doesn't do that, but because that is her method of care, as low risk as much as she can, right? In a safe way. But not knowing that there's midwives who also do just the same as she does. When you get patients like that, what's your response to
What's
that?
my response? First, I ask why, just to see like where it's coming from, because everyone has their own story or background as to why they prefer one person over the other, and then basically educating them that, hey, I can do the same thing as Dr. Pemberton could or any other doctor could in this stance, and this is where we differ, and then from then on it's also their choice.
And what is the difference between you and an OBGYN? So they call it OB-GYN, right?
OB-GYN, OBGYN.
Yeah, right? I'm old, so we used to call it OBGYN. Now the younger folks are saying OB-GYN. I was like, you're doing what?
We're gonna go to OB. That's it.
Yeah,
we're gonna go to the OB. The biggest difference is that OBGYNs deal with high-risk women, so they can perform the C-sections and deal with anything that's more complicated. As midwives, we deal with low risk, so normal vaginal deliveries. There are some midwives who do certify to help first assist C-sections, but that's not our main objective. So I would say the biggest difference is if you needed a higher level of care, then an OBGYN is where.
What kind of patients would risk out of being in a midwifery model of care? Like if I had, I'm thinking like diabetes or high blood pressure, at what point is it where I think you should see a doctor or you should see our physician?
So it's not more so as of risking out of care, but more so a collaborative approach, because we do learn the same things in school, but it's important to know that with midwives and doctors, we work together, right? So if there's any patients who seems to be heading in the direction where they need a higher level of care or collaboration, then that's where we step in and ask, Dr. Pemberton, or if you work in a different practice, your physician, for what their expertise and recommendation is, and we work together to still take care of the patient.
Got it. And do you feel like your relationship with Dr. Pemberton is like where she fully trusts, she'll stand back and kind of like let you do your own thing and as long as safe? Like do you feel like that's?
Yeah, I definitely feel like that's our relationship. Sometimes I feel like we're a lot alike. So we kind of get each other. I feel like it's important to work with your physician, and because you work very closely together, right? So having that like repertoire, like relationship where you can trust that each other can handle their situations, and she trusts me enough to know that if I'm calling her for something or need her advice, then it's because I'm sure of it.
Yeah. So, and I know doulas work very much together with midwives. What is the importance of that relationship?
We're pals.
Yes, besties.
What are you? Happy and
no, we work very well together, and I think it's kind of a blessing when there is that vibe.
Yeah.
Right. When
you
mesh,
you just see sync.
It's like the best.
You get the this is the objective.
Yes.
Yeah.
And,
I mean, we're there for the same reason. We're there for the same purpose, and our approaches are just slightly different. So obviously I'm not doing anything medical, even if it's low risk or not. So my focus is just support and information and advocacy and really ensuring that person is comfortable, with whatever particular birth experience they're trying to have, whether it's normal, natural, and physiologic, or if it is C-section. I still want them to have a level of calm and comfort. And, that works hand in hand with the midwife who's also doing the same, but like from a different lens.
Yeah.
And so we really are kind of that layered approach of support.
So you get the full team. Like if you have a midwife, you have a good RN, and you have a doula, that's like the dream team, right? Mm-hmm. You have the highest success of a unmedicated birth, or
You just have a great success story of empowerment, of feeling. I remember one of our clients made a mention to having that layered approach, and she said, I felt like I was in a womb of my own. She felt
nice.
she felt loved and nurtured and cared for. And so when you have all of those layers of people who have specific roles to do and are doing it well and meshed together and everybody's vibing, like it's a beautiful experience, no matter what the birth outcome is or how the birth is going. If that person is still supported in a way that makes them feel very comfortable and confident about all of their choices and all of their options and getting informed consent in the process, there's nothing better, hands down.
That's awesome. And midwives don't only see births, right? Like you guys do other things that you do. You do GYN also. Yeah. Why is it so not? I feel like it's just not talked about. It's not like, you know what? I'm gonna go see my midwife for my GYN appointment, and it's usually like I'm gonna go see my doctor. But you guys do the full aspect of
from A to Z.
Do it all. You have your wellness. Now, what does your scope in GYN? What does that look like?
As far as we deal with all sorts of things, abnormal vaginal bleeding, regular annual visits, problem visits, pretty much do it all. Now, of course, as you get certified in other things, you can do like biopsies and colposcopies, but the baseline, we can do it as much as the OB can.
Yeah. And I feel like you guys are more in tune with a patient in a sense of like, I see you as a person, right? Like, I know your hobbies. I know, like, I want to know you as a person, and you get comfortable with them versus, like, your traditional.
There's a better relationship, mostly because sometimes that time limit isn't there with appointments as much. But also, I think that just for me, like in the classes, like I'll tell people that because they want to know like what's the difference. I go, just think of it as your midwife is doing all the things that your doctor can do. Your doctor has added on an additional skill set of surgery. Right. So all of those other things, that's where the limit stops. Like, where they're not going to be performing your C-section.
Yeah. That's cool. And do you feel like your schedule reflects more OBs than GYN?
I would say so.
Yeah.
I mean, mostly because most of the OBs would like to see their potential provider who would be delivering them. But there's a nice mix in there still.
Do you get a lot of postpartum people that come back like, all right, you delivered me, so I'm just gonna stick with you at this point.
People get comfortable. You know, a lot of people don't like change, especially in intimate settings such as GYN.
I don't like change. If you saw me, right?
I will owe you to
that's it.
All the stuff.
We're not switching.
All the stuff. Which I get, because even I'm like that. So definitely, your patients who get comfortable with you, you build that relationship, they just want to stick with you. So it's nice seeing them from the beginning to the end.
And then you see the babies grow.
I always tell them, bring your babies back. Full circle moment.
Yeah.
Oh, that's the best.
That is the best. When you see them and they're like 5, 6 years, you're like, wow.
I can't believe
time went that fast. And have you had, and I know you're a twin, and I'm going to keep saying that, but like, have you delivered twins? Are you able to deliver twins?
I am under the supervision of an OB, which is funny you say that because me and Dr. Pemberton actually delivered twins a month ago.
Oh, yay.
What was that like?
It was an amazing experience. It was my first, so I was a little, but she was like, you got this, you got this. Doc is very
both of you guys delivering a twin is,
I know,
it's pretty dope.
So it was
awesome.
Cool.
That is awesome. Yeah. And so where does it turn to then you have to give it to the physician for a twin? Because I know it can kind of get a little complicated.
Yeah, so with twins, just making sure both are head down is the biggest thing. So just even having extra hands other than Dr. Pemberton or another physician is more so once the first baby comes out, just making sure the second baby is also
How do you tell?
still. With the ultrasound, and just by making sure you're applying pressure and holding. And then once that's confirmed, then it's just like a normal delivery.
Oh, nice. Okay.
It's really more so the second baby that's the concern, not more so the first. Because twins like to be tricky.
Oh, as long as that second baby's not 4 minutes behind. I guess they won't have to worry about it, right? 4 minutes. She's like, I'm an older child by 4 minutes.
It's important.
And don't you forget it.
What else did I have? I felt like you guys, because there's certified nurse midwives. Then there's, what is a CPM?
So certified professional midwife is a CPM.
And then you have a CM.
CM, which is a certified midwife.
What are the difference between all three of them?
It's just as far as training and how you're educated. As far as certified nurse midwife, which is what I am, I have a nursing background. So I was a nurse first before I went back to midwifery school. Now for CMs and CPMs, their training is more so traditional in the form that they get hands-on training first or throughout, and then they're more limited into where they can assist births.
CPMs and CMs.
Correct.
Interesting. Okay, so you don't have. Do they go to school?
Yes, they go to school.
Okay, and CMs are able to do home births, right? Are you able to do home births?
Yes, I'm able to deliver anywhere.
Technically, I think New Jersey is like one of the lenients with.
New Jersey is really decent with that in the stance that CPMs and CMs have like more options than other states.
Yeah.
Like CPMs can deliver in birth centers.
Yeah.
As opposed to just home births. But they won't be in a hospital space.
Yeah. So I know the CPMs and the CMs can't deliver in the hospital. That's cool. That's pretty cool that you have like different levels of midwives. And I know in the state of, if I'm not mistaken, I think it's a state of Texas, I was reading that they have like stopped so many midwives from practicing. And it's just, it's sad.
It's very disheartening.
Yeah.
It really is.
It's about control and money and insurance and just all the things that make medical care sucky.
It's true. I mean, honestly, I feel like it's such a gift to have, you know, someone, a midwife, because I also heard that there's men midwives. I haven't seen one, but I heard there was a few of them.
I met one, and he was cool. I loved him.
I don't know. I think I'd feel some type of way about
it. Was, you know. But hey,
I mean, there are men doulas, and I'm actually mentoring.
Oh wow,
how's that experience?
Men doulas.
It's a support system, though. Like I feel like we make it so like you have to be a woman, or not you have to, but like we're so accustomed to seeing just women.
It's like what's traditional,
yeah,
right? And then what do you? Because you know, my thing is, what's your comfort level, right?
Correct,
because if you're feeling okay with opening, you know, yourself up to that individual, then that's cool.
Yeah.
I mean, there are a lot of OBGYNs that are male, right?
Yeah.
So why are we freaking out about a male midwife?
Yeah.
Right. But it still is just what's been traditional in that role that makes people go, ooh, what? Oh, that's different.
Yeah, that's different.
And so in a delivery, and I'm asking because I'm thinking of like the medical, what a delivery looks like to you as a midwife, which versus a doctor. What is the difference? And I know you know, to you, it's probably because you work both aspects. You do work in a hospital and you work in a birth center. And I know it's a little more, at least in my aspects of the birth center, we don't have so much intervention. What is that like for you working in a hospital with different doctors? And I know you work with docs, so docs, you know, purpose is you guys have the same goal.
Correct.
What is it like for you working in a hospital, and what is the difference that you see medically versus at a birth center? That was a loaded question, right?
Yeah, well, I'm trying to like pick the parts, but essentially more interventions, right? But in the fact of when it comes to us and our practice and how we deal with our patients, but also knowing we're working with a hospital who doesn't see that other side of birth and aren't used to it. It's kind of like a push and pull, like kind of like educating that not everything has to be a heightened situation. Of course, when you're working with other physicians who all they're used to knowing is high risk or how bad it can get, they're always going to treat every birth that way. And sometimes you can't fault them, right? But just trying to reel them back to, this is a new patient, a new scenario, everything's going well, we're going to continue to treat it as it's going well. So, I mean, in a sense...
Can I say something? Yeah. Because I got to witness her in both places.
Okay.
Right?
So give me a picture, because I want to know.
What I absolutely... Because she's going to be really like, oh, yeah, it's the same, you know, and I do the same.
It's okay.
She's freaking awesome.
Oh, okay? I've done a couple of deliveries. So we were the dream team once.
It was... The thing about it is, when you're in a birth center, you know, all the things are just calm, we're taking it slow, I hate to use the word allow, but we're, you know, allowing birth to birth and to do exactly what it's supposed to do. Obviously, Shajara's going to be like on it, on 10, in the birth space, at the birth center, doing it. I got to see her in the hospital.
Oh.
I loved when she walked in, the command, the confidence, the way she like parted like the seas in that moment where everybody was like, and she was like, we're going to do this. And it's going to happen this way. And this is what's going down.
I can see that. And
Mom is just going to push.
She's so humble.
Okay. Right. Yeah. That's why I'm, you know, didn't mean to interrupt you. But I had to say that because it's what people need.
Yeah.
You know, if you were understanding what is completely normal and natural about birth, and you're looking at stuff and you're seeing ain't nothing going wrong. Where's the hyperbole coming from?
Why are we being so extra?
And there's like all this, we got to get ready. We got to get NICU. We got to do da-da-da. We got to, you know, and it's like, we're good. We're fine. She's gonna push, and here comes the baby, and it's, you know, and it was just what Mom needed.
Yeah,
was just this calm presence to be able, you know, nobody needs to be screaming 10, counting to 10 when it's time to push. First of all, Mom knows how to count. She knows her waves. She knows that they're coming. What are we doing right now?
Yeah.
Where's all the noise and the hype? It's not necessary. And I loved the way you just brought like just the centering and the focus, because I think one of the things that wasn't mentioned is that midwifery model of care is all about the family and centering the individual and the person in that space, because they matter the most. Not what everybody else is doing.
And your midwife is part of your village. I feel like your midwife is such a key part of your village, you know? And I did a birth with Shadira, and it was a patient who was, it was one of like the most relaxed births I've had. Not that I haven't had any, but it was just, we just clicked. And this patient was so anxious. It was her first birth center birth, and she was just so unsure of herself. And Shadira was just like, you got this. Like, we see the baby. It's okay. And I'm, you know, listening, giving her the sweet nothings in her ear, right? I'm just like, you're doing so good. Encouraging her, you know, the doula, because I was a fake doula that day.
That's all right.
You know, but
that's okay. I'll give you a pass.
I learned from the best. But it was so nice. She had an amazing birth. And it, you know, she was thanking us so much, because it was just, she did not think she was going to have
be able to do it.
And it was just, it was really nice to see that transition so flawlessly, you know, versus having the loud and the go, and it was just
extra
really
coaching
nice.
sometimes.
Michelle, you've worked with a lot of different midwives, because you've been in the game for a long time. Well, not to age you, but you know.
Well, tomorrow's my birthday, so let's be real.
Oh, happy early birthday! Yay!
Yes, gonna be 58.
Looking like a whole snack. All right, I see you.
Right, but yeah, been a doula for going on 19 years.
Wow. So you've worked with midwives in the hospital, in a birth center. Have you done home births?
I started off the first 5 years were mostly home births.
You did? You had your baby?
I had my baby
at home.
Yes.
So you've had like you had scopes of everywhere.
Yeah.
Have you ever worked with a midwife where you were just like, no, this is too much?
Yes.
Where you're just like, this is not what we signed up for.
Yeah, like, not to be weird or anything, but there's like this phrase that we say, we sometimes call midwives medwives if they're not actually following the midwifery model of care, if they're not following evidence, if they're not doing things in a very evidence-based kind of way, right? Yeah. Some folks are traditional. Some folks are doing things that they're comfortable with, or what's out of their scope of practice, or maybe what they have been trained to do by OBGYNs who are not as comfortable, following normal, natural, physiologic birth. So, yes, there have been multiple times when I've been in a space where I turn around and look, you're a midwife?
Yeah, like, like, are we sure here?
Like,
are you sure?
Yeah.
Doctor?
Why are we doing that? And just random stuff. Like, just to kind of maybe it's like a CYA kind of thing.
Yeah.
Maybe they feel like somebody else might come down on them if they didn't follow this particular protocol or procedure. But it has been interesting. And as a doula, I would have to kind of help my client understand why they didn't get the birth that they wanted.
That's rough.
In that space, because these things weren't allowed, or stuff had changed, or clearly a midwife was like, no, we're not doing that, or went in and did some.
But you could be the advocate, right? Like you're the advocate for your patient, because we're not, as a patient, right? Sometimes I'm not in the right state of mind, or even in a clear, concise chain of thought where I'm just like, okay, this is what I wanted. Sometimes you're just thinking in the moment, this is what I need right now. But you, after I spoke to you about my birth plan, what I want, you're like, no, we're sticking to this. This is what you originally wanted. And are you able to tell that midwife that, or are you able to kind of like...
There are multiple times when, advocacy can look very different in the space, and I try not to be, boisterous or antagonistic or anything like that. And I do check with the parents again, because sometimes even, you can write something on your birth plan, but then in the moment, change your mind.
Yeah.
Right. So it's, I don't want to be like just stuck on stupid if this is really where we're changing and we shifted. So now it's like just a correction and really kind of a check-in. Is this what you wanted? Midwife XYZ is about to do so and so and so. Are you still okay with that?
Yeah.
Right. And so that's really where, for me, advocacy works in the amplification of that individual's voice. So I'm not necessarily speaking for that client, but if I see something, I'm going to say something. Like that's
Have you ever had to put your foot down? Like, she said no.
Yes.
Give me an example.
Okay.
I want to know the tea.
She's like, which one do you
want?
Yeah,
I want the tea.
Well, there have been a couple of circumstances where things like breaking your bag of waters were done, like just for no reason at all. Like, you're laboring, we're doing a good job, contractions are coming, and then all of a sudden somebody just goes, well, if I break your bag of water, this is going to go faster.
Yeah.
Do you want it to go faster?
I was gonna say.
Are we, like, what's wrong with the pace that we're at?
Yeah.
Like, why are we not, hanging out here and just vibing and enjoying,
On that, do you feel like you see a lot of midwives who come from a hospital base where it's just like, she's not laboring fast enough for me, and, and because I've personally seen it.
I've seen it.
Yeah.
Even working like before I became a midwife as a nurse, I've seen both spectrums. I've seen the midwives, which is what we call them.
You call them that too?
Oh, definitely.
Okay. I thought that was just a doula thing.
I've seen midwives and I've seen midwives, and I've seen, you know, the stark difference. And I just think it boils down to, like Michelle said, like background and training of who trained them, and then also burnout as well. Like when things are fast paced or you're stressed a lot of people don't know how to handle it. Fortunately, that's not the right career, but you know, different things are done without patient's consent, which is unfortunate. But I've seen it happen.
Very unfortunate.
Yeah,
super unfortunate.
Yeah, it's never fun to witness. You know, there's what was it, secondhand post-traumatic trauma, like to just
seriously.
Sit. Yeah, I mean to watch someone be abused is not cool either. You know, recently there was, you know, a birth where there was a whole placenta being ripped out of somebody's body because we just didn't want to wait
for the detachment,
for it to detach,
and that causes postpartum hemorrhaging.
Yeah, can cause postpartum hemorrhage, infection, which can lead to sepsis. So different things that aren't.
It was, you know, I could see if it was like needed, if we waited, if it was like 45 minutes and still nothing was going on, you know? I mean, I could see wanting to escalate that situation. But
even then, I've seen midwives wait almost like over an hour.
We hear up to an hour. We're chill. Right.
And at that point you have the golden hour where skin to skin.
Absolutely.
And we could just let them enjoy their bond. And she just
help. Also.
She kept intervening.
Yeah. In her mind, it was this needs to come out immediately. And, you know, there were really no indications that it needed to come out that fast.
And I feel like you get that. I feel like in a hospital, like I've experienced in my birth I was able to actually experience both the birth center and the hospital, right? So I was able to see what it was, and it was magical being here. And I was able to have both the midwife and I had Dr. Pemberton. And when I went to the hospital, you know, Doc laid the law. She was like, nah.
She's another one who kind of parts the seas when she walks into
you can definitely tell.
And I love it. And people either love her or hate her, and she's cool with whatever.
Yeah.
Because doesn't matter. You're still going to do what I want to do. At my right? Like
this is my patient.
Yeah. I mean, I love the way she kind of you know, like pulls you aside and has like a little come to Jesus moment. Yeah. And like, let me tell you what you're not going to do.
Exactly.
Right now in this space.
And I can tell she sure did have that conversation before I got there, because it was, I was able to have that birth center experience. I was like, I need to not be strapped to a bed. I can't do that. Like, not coming from the freedom of doing whatever I walked around. I was able to eat, like, and then going to not saying that the hospital is a bad experience, but now I've gotten, it's like, whoo, and then you're kind of
and you're restricted, and you're treated as if something's wrong with you, and you're you know, you had to come to the hospital for a specific reason, but doesn't necessarily mean it has to come with all the accoutrement of you know, all the bells and whistles of what's, you know, potentially wrong with other births. So it's like, look at me as an individual, look at my situation, and then just, you know, parse through that and let's figure out what I need.
I just feel like the difference between a birth center and a hospital, experiencing it myself, was just, it's so different. It's so different. And just bringing a birth center experience in your head to a hospital it really could lighten the entire mood, and I feel like a lot of patients don't see that. But I think we'll wrap it up here. It was a pleasure speaking to you guys. You know, I don't get the experience of being here. I usually am back there, but I appreciated this, and tune in to our next episode. If you guys have questions, comments, concerns, anything, please comment on our IG page and our YouTube, and we'll see you in the next episode. Bye.
Bye.